including low access to the rehabilitation services, poor funding, poor awareness among the general population as well as the medical fraternity, and the low quality of the rehabilitation services. The aim of this webinar is to improve the quality of rehabilitation services in India through better training of the rehab professionals, as well as the medical professionals and the allied health involved in rehab care of amputees. So we have speakers from Australia, UK, and India. We have included the allied health team because we think that the rehab talks are never complete without their valuable presence. So the learning objectives of today's webinar will be to learn more about ideal residual limb requirements, when to start and how to progress with amputee rehab, and to know more about the cost-effective prosthetic prescription. We are also presenting or proposing a model of care through KIMS Health Limb Center. We have organized the webinar into 2 sessions. The first session will be on amputee care in Australia, where we have got the multidisciplinary team from Australia who will be talking to us. We have Ms. Shannon Patton, who is the prosthetist, Ms. Monique Jones, who is the physio, and Dr. Charita Pereira, who is the rehabilitation consultant. And this will be followed by a panel discussion. The panel discussion, during the panel discussion, I'll take up the questions that you post in the chat box. And session 2, we have Dr. Prasad Matthews talking to us about amputee rehabilitation in UK. And Dr. Fatima Hanina from our center will be presenting a case on myoelectric limb and will be detailing about the rehabilitation that is undergoing at KIMS Health Limb Center. Thank you for joining us today. So before we begin the session, I would like to invite the chairman and managing director of KIMS Health, Dr. M.I. Sahdullah, to bless us with his presence. Dr. M.I. Sahdullah thank you for joining, sir. Dr. M.I. Sahdullah is a physician by profession. He did his general medicine from Medical College Trivandrum, and he is a fellow in a fellow of the Royal College of Physicians, London and Ireland, and he has his MBA from UK. He has been very much supportive for the rehabilitation services at KIMS Health. Thank you for joining us, sir.
All right, I'll say a few words. All right, Lakshmi. Yeah, thank you very much. Everyone, good morning to all of you. It's always great to be part of such good sessions and good activities. KIMS Health has taken this as a pride in the rehabilitation as well as the amputee services, as a pride to as our CSR activity. And I want to really thank Dr. Lakshmi Nair and the team. And my guru in the rehabilitation is Dr. Prasad Matthews. And he was with us, but now he's in the UK. And also, thank Dr. Fatima Hanina, who is one of our faculty. I welcome and thank really the speakers from Australia and who have joined this session. And I am sure that whoever is interested in this area will be highly benefiting from this session. I think the rehabilitation and amputee, rehabilitation has really come up a big way. And when I got involved in this one, I never thought that it is so deep and perhaps complicated, and there is a lot of scope. We can do a lot of services to the public. I learned, I'm still learning a lot in this area, and we want to do better and better rehab in this area for our people. In fact, in Kerala, we are located in Kerala for those who are from outside. I was thinking that there may not be so many amputees, but to my surprise, we have already done 500 or more. Dr. Lakshmi should be knowing the statistics. And then we are trying to really develop the quality of the product more and more. We are trying to involve our space research organization along with us. We are involved in some other areas. And in the GCC, that means in the Gulf countries, in the Middle East, we are promoting rehabilitation with a company from France called Orpea. And so we would like to take rehabilitation as one of the specialties of Kim's Health. Once again, welcome to all the faculty and the speakers. And thank you very much, Lakshmi and team, for organizing such a thing, such a conference, and it's a learning experience for all of us. And Dr. Prasad Matthews, and especially for joining from UK. That's all from me. All the best. Thank you very much. Over to you, Dr. Lakshmi.
Thank you so much, sir. Let's start the sessions. So we have the first session on amputee rehab in Australia. So before starting the session, I would like to give you a short brief about what is happening there. So the vascular surgeons will be doing amputations in Australia. And most of the patients who are having a planned amputation get pre-amputation counseling. And post-operatively, the P&O will be going into the recovery room and giving a removable rigid dressing. And within a week's time, the patient will be transferred under the care of the rehabilitation consultant. The rehab team takes care of the patient from there onwards. They work as a team towards to attain the maximum functional ability and improve the quality of life of the patient, where the physios will be concentrating on the mobility of the patient. Occupational therapists will be dealing with the daily training in ADLs, daily activities, and as well as the proper wheelchair prescription, setting up the home for discharge, like that. The rehab consultant will be taking care of the medical issues, the pain management, the complications that can arise in early subacute period. We have the wound nurses taking care of the wound dressing. They do the suture removal, they do vac dressing, everything, and they inform the doctors in case of any concerns. They might also get services from the psychologist for the proper backup. And the social worker will facilitate the smooth discharge to home. They will arrange transportation. They will make sure that the services out there in the community are reachable for them. So this is a brief about what is happening. Now let's move on to the sessions. First session, we have Shannon Patton. She is the clinical prosthetist and orthotist at the Orthotics and Prosthetics South Australia. She graduated from La Trobe University. She worked at the Women and Children Hospital. And from 2018, she is working at the Orthotics and Prosthetics South Australia, where she is involved in the care of patients in the acute hospital, outpatient prosthetics and orthotics for both pediatric as well as adult patients. She is also involved in the interim prosthetic rehabilitation program, where she will work along with the physio. She also does country outreach clinic visits at Mount Gambier. She'll be talking on ideal residual limb requirements and cost-effective prosthetic prescription, amputee rehabilitation from a prosthetist perspective. Over to you, Shannon.
Hi, everyone. My name is Shannon. I'm a prosthetist orthotist that works at Orthotics and Prosthetics SA. So we're part of the Southern Adelaide Local Health Network in South Australia. And I'm going to be talking to you about amputee rehabilitation from the prosthetist perspective. So here's some statistics that we've found in regards to amputations in India. So the most common ages of amputation are between 21 to 30, followed closely by 31 to 40. Out of all the amputations, 86% of those are male, and 70% of those are from trauma. If you break that down further, the biggest causes were road accidents, railway accidents, burns due to fire, electrocution, and chemical injuries. And that is followed with 27% of peripheral vascular disease, and then 3% of carcinomas, which is usually prevalent in the younger generations. So if we compare that, though, to Western populations, various sources basically all report that peripheral vascular disease is the largest cause of amputation, with the older generations being more affected and predominantly having male amputees as opposed to female. So considering 95% of all amputations are of the lower limb, here's just a bit of a breakdown of the different amputation levels of the lower limb. So it's important to note in particular the differences between transfemoral and transtibial amputees. So transfemoral obviously has the higher rates of healing because of improved vascularization, but there is a 50 to 90% increase in energy expenditure, whereas transtibial, which is the most common lower limb amputation, and also has the highest success rate in potential rehab, they have 10 to 40% increased energy expenditure. So immediately post-surgery here in Australia, we like to supply what's called an RRD, which stands for rigid removable dressing, used purely only for our below-knee amputees. So it's a fiberglass sock that's rolled onto the bottom of the stump, and it's best applied within less than 2 hours. So we like to grab people post-surgery in recovery, but it can be applied within 24 hours. So that basically allows us to remove the dressing, have the doctors have a look at the wound. All dressings are very superficial to prevent any further pressure areas. It also, in the first few weeks, offers that protection to the stump in case the patient's to knock it, and also allow for some desensitization to the skin and the surrounding tissues. So that is continuously worn when a patient does not have their prosthesis on throughout our rehab process. So once stitches are removed, we start using what are called shrinkers, which are compression style garments, and basically they're used for below knees and for above knees. So primarily used for volume control and shape contouring. And we get them to wear that for 1 to 2 weeks before their first prosthetic casting appointment. So ideal stumps. So we never want stumps that are too long because this limits our choice in componentry with our transtibial amputees. So the whole idea of max length is best is not always appropriate, because in that case they would have therefore a really low profile foot, which decreases the energy output that they can receive. With our transfemoral amputees, if there is a large length, this can eat into some of their shank build height. So as a result, they have 2 different knee center heights. But in saying that, they do then have a greater lever arm in regards to future gait trainings. Additionally, there needs to be enough good tissue to have healing, considering a lot of amputations around the world are from peripheral vascular disease. We need to make sure that the wounds are healing. And then also in regards to the redundant tissue, we need to make sure that we're controlling that redundant tissue as much as possible. And our suture lines, we want to make sure, especially with our trans tibs and their posterior flaps, that the suture line doesn't adhere to the bone. So we like to get that tissue nice and mobile over the bone as soon as possible. So in regards to the shape, or the anatomy, I should say, sorry, the biggest issue we normally face is just making sure that that fibula is beveled for our below knees, for both our below knees and our above knees, that all bones, including the tibia and the femur, are beveled. With our knee disartics, it's easier if the patella is just not there. It's less bones to sort of fiddle around and locate. Sometimes they can be in interesting places. You also get the ability to have a self-suspending or a plug fit socket. And that is similar with our congenitals as well. They have the ability to have a self-suspending prosthesis. And lastly, all amputees, we do like that there is nerve excisions or replacements, movement or placement of nerve endings. So no neuromas or nerve issues come up in the future. So skin presentations. So around the 3-week mark, our stitches get removed, and that is done by our amputee nurse practitioner. And that's usually done in 2 stages, so the wound doesn't dehisce. And we never ever start prosthetics until we're completely healed, and our nurse practitioner is the one who gives the okay to go ahead with that. So from there, long-term issues and also, I guess, acute issues is that adhesion from so posterior flaps with the trans tibs, to make sure that that tissue is nice and mobile. So we get our amputees to learn to start moving that tissue over the top of the bone and just breaking up any little bits of scar tissue that we can, because with the adhesions that can make wearing a prosthesis at a later date as a long-term user a bit uncomfortable. And that additionally, invaginations can occur from that excess redundant tissue that we don't want. So we want to make sure as much tissue is contoured as much as possible, but there will be future atrophy anyways. So it's just something we need to be careful of. Tissue compliance is also another really big one, especially in Australia. We notice with our older generations of amputees that their skin is very fragile and vulnerable. So we've noticed that if they start prosthetics without any sort of gel liners, the tissues break down very easily. So we want to make sure that that skin is really tolerant to shear forces. So if not, we use the gel. And it's very similar with trauma in regards to scar tissue and grafting. At the start, it's just very fragile. So we just need to be very careful and very cautious about what pressures we're putting on particular areas. So in South Australia, we use modular style componentry, but every state is funded slightly differently, but it's usually all state run, but most places, I would assume, would use modular. So we don't usually start, obviously, until they're healed and they have their 2 weeks or 1 to 2 weeks in shrinkers before we cast. And then we've got a 1D 10 foot on that prosthesis there in the photo with some tube clamps and a pylon with a P-light liner and a fiberglass socket and a sleeve. So some of those components we do recycle at least 3 times. So we have 3 sets of new amps coming through that will use that before we have to remove them from the program because of warranty reasons. So cost-effective componentry. So a colleague of mine went to Sri Lanka a couple of years ago and learned all about the Japor foot. So I personally haven't worked with it myself, but from what I've been told, they're waterproof, extremely durable, and in most cases made in-house. And cost effective wise, that has been, I guess, the best that has been around for a number of years. In Australia, our comparison versions that we use in our interim program is the 1D10 or the 1D11, one just being a narrow style of that foot. So they're slightly more dynamic than the Satch foot. So there's a smoother rollover, and there's also the split toe 2. And then the waterproof version is the Otterbeck 1WR95, which also has a split toe, and there's tread on the sole. So I guess the downside to any of these feet, unfortunately, they're not great for outdoor use. The materials would break down way too quickly. We always suggest to patients, like, wear shoes if you want it to last. But they can be worn indoors, I guess, for short periods of time because the surfaces aren't as sort of severe as asphalt or dirt or concrete, etc. So still sort of talking down the modular line in which we use in rehab here in South Australia. So we've got our modular adapters. So I like to use the American Prosthetic Components because they are weight rated to 166 kilos, which covers a broad range of the weight ranges of our patients, and only use a 30 mil adapter. So it has also a good range of these angled tube clamps, different materials. You can use stainless steel, aluminium, which was waterproof and corrosion resistant, and titanium as well. And they can all be purchased in sets to decrease their costs. Again, from my colleague that visited Sri Lanka, the knee that I was told about was the Stanford Japor knee, which has been extremely cost effective, is my understanding. And it's also a polycentric knee, which will give greater stability compared to a single axis knee. And then I guess there's the whole idea of componentry warranties on a modular versus exoskeletal, what's more cost effective. So a lot of the warranties on the modular components have roughly 3-year warranties, some slightly less. And that way we only change the sockets, which is more cost effective in South Australia for us, and also allows for greater alignment changes post that initial fitting. So we've found, working with the physiotherapist Monique and myself over the time, we've noticed that as people get stronger, more confident on their leg, their alignment normally needs to change to optimize their gait. But also on the other side, exoskeletals, you're only really using manufacture time and the materials are significantly cheaper. So in regards to the sockets, the sleeve versus the cuff, with the sleeve, we've noticed and started using these as a first preference base because the quads have wasted on some of the people using cuffs, but cuffs, again, extremely more durable and last a lot longer, whereas the gel can sometimes start to break away after a period of time. With the P-light liners, because we use the P-light liners inside the fiberglass sockets, they're our most cost-effective versions because we're able to add additional packing, add extra socks, grind away material if there's too much pressure somewhere, or heat out the fiberglass if needed. And then there's lastly the gel liners that I was talking about when we use those for our older generations with extremely fragile skin, or someone that's come through with significant skin grafting, or large areas of scar tissue. So we use those sort of straight off the bat because we don't want to waste time in having them have their skin break down and then having to be non-prosthetic for a period of time, waiting for it to heal, and then having to pick back up where they left off. It just interrupts that rehab process, I guess. So yeah, that's all I have to add, but thank you very much for your time.
Thank you so much, Shannon. That was an enlightening talk. We could learn more about the ideal prosthetic stum requirements as well as the cost-effective prosthetic prescription. Next, we move on to Monique Johns. Ms. Monique Johns is the principal physiotherapist in the Amputee Rehabilitation Division, at Flinders Medical Centre, South Australia. She has got more than 10 years of experience as a rehab physio. For the past 3 years, she was working at the Amputee Rehabilitation Division as the principal physiotherapist. She'll be talking to us on amputee rehabilitation from a physio's perspective, how early to start and how to progress with amputee rehab. Over to you, Monique.
Hi everyone, my name is Monique and I'm going to talk today about amputee rehab from the physiotherapist perspective. So in terms of what's brought me to this point, I've basically worked in rehab for about 10 years, with the last 3 of them being 3.5 or so being in amputee rehab. And the main, it's mainly on the job learning here, aside from a 1-week course and then other sort of bits of professional development and courses along the way. But the 1-week course is the main sort of education around amputee specific rehab and prosthetic rehab. So one of the questions pitched to me for this presentation was, when you think about amputee rehab, how early to start? And I think there's 2 elements to that. One is prosthetic rehab and that sort of thing, and that has to wait a while, and that's based on many factors that our talks today will attest to. But realistically, part of the preparation and the general rehab is starting basically immediately post-op. Following that is then pre-prosthetic stage and then prosthetic stage for patients who do end up actually being prosthetic. So let's go into some more detail about those. In terms of immediate post-op care, so straight after the amputation, there's a multidisciplinary approach here around starting that recovery period and the early acute care side of the rehabilitation in terms of getting people moving, thinking about chest care. Obviously, we're trying to avoid any of the secondary complications of being rest in bed, so hospital-acquired pneumonias and that sort of thing. Pain management is really important at this phase in terms of people being able to participate. We're thinking about stump and edema management, and the prosthetist will talk to the rigid removable dressing, or RRD, that we apply for below-knee amputees, who are our most common group. Avoidance of contractures, which I'll go into a bit later, and then, as I mentioned, getting people moving, so bed mobility and transfers and that sort of thing, starting with something as simple like rolling and then working towards sitting on the edge of the bed, transferring out of bed. In terms of the immediate post-op care, this is often sort of the scene we see, and it can be a little bit intimidating, but I guess the goal is problem solving through and working out when the patient is ready to start transferring out of bed, and then what is the safe way to make that happen. So a couple of options we think about. The lowest level would be what we call a sling lifter, where the person's being lifted up in sort of a hammock with a machine and being slung across to another surface. But once the person can sort of roll, get up to sitting on the edge of the bed and has some sitting balance, we're thinking about either a slide board transfer as our lower level of the options in this realm. So as you can see in the picture there, the gent's sliding across from the chair across to the physio bed there on a board. So it doesn't require that leg strength that a pivot transfer does. A pivot is where you're actually taking your weight onto your leg, getting some bottom clearance, and then swiveling around and having a seat. So some of the factors that influence your decision are outlined there. For bilateral amputees, we can get a bit more creative and think about that forward-backward transfer, like what's in the cartoon image. Some bilateral amputees do like to still go sideways, so then we're using our slide board. Most of the time, although if you've got phenomenal upper limb strength, some don't need the slide board, but there is still shearing forces on the bottom, so we need to be careful. If they're a bilateral amputee, but their amputations were done some time apart and they've got a prosthesis on one side, then some can pivot on a prosthesis, but we need to be quite cautious because of the shearing forces that are then going through that stump if they're pivoting in the prosthetic socket. In terms of getting in and out of the car, again, we're thinking about a pivot or a slide board option, and on and off the floor is another transfer that we're always thinking about, with amputees being at a significantly higher risk of falls. Standing and hopping are another thing that we're thinking about, so getting them standing up on the leg if they can. Obviously, if there are other injuries and they're not cleared to weight bear and that sort of thing, it needs to be factored in. But if we're good to go, then we'll definitely be working on standing endurance and standing balance. However, in terms of hopping, we're quite reluctant to hop. Most of our population of amputees are diabetic vasculopaths, which means that the remaining lower limb is at a really high risk of injury and wounds and that sort of thing. So we're quite careful about whether we should be introducing those forces. But it does happen, and you can see a gent standing there with a frame ready to potentially do some hopping practice. We start in the parallel bars and then we progress from there to see if it can become functional out with the gait aid. So then we start thinking about pre-prosthetic rehab. So this is where they've hopefully achieved some amount of independence if they can, or a version of options for transfers, bed to chair, etc. They can get around either in the wheelchair or with hopping. But then we're thinking about pre-prosthetic rehab, and if the person's going to be prosthetic, obviously we're trying to optimize all of these things. So thinking about wound healing, minimal contractures, thinking about stump shape, which I'm sure has come up in a couple of the other presentations. And we do some work in trying to shape stumps with the RRD, the rigid removable dressing, shrinkers, which is a strong compressive garment that I've got an image of later, and things like that. So we can do some work to try and help make a stump have a more optimal shape. And then the prosthetist works quite hard to work with what they've got, because we'd rather give people the opportunity with a prosthesis than not. Knowing that tissues can change ideally with pressures and the right treatment to a certain extent. I'm thinking about general fitness, because all of this takes a lot of energy. Donning and doffing the leg takes a lot of energy, particularly if you're an above knee amputee. That has to be done in standing. And also the energy requirements just on your endurance to actually then walk around with a prosthesis. Specific stump strength. So the prosthesis is a passive device. Some are sort of energy storing and that kind of thing, but we like to treat it as though, okay, you've got your prosthesis, now you need to actually be able to use it. So you need the strength to actually maintain the extension, go through hip extension, and actually have ideally some functional use of that prosthesis once it's attached to you. And then we're thinking about weight bearing. Can you weight bear on your contralateral limb, weight bearing through the upper limbs, through gait aids and that sort of thing. And obviously balance is always really important. I'll just go back to that. You can see in these images, so we've got some people doing their pre-prosthetic rehab. So this gentleman's doing an arm cycle, which is what we use as an option for cardiovascular fitness. And then the patients laying on their front, they're stretching out their hip flexors, working into hip extension and that sort of thing. We find that the risk of contractures is primarily in the hip flexors and the knee flexors. So we're trying to make sure that we're maintaining hip extension through exercises in prone, in standing, and doing quite a few repetitions of those each day, and also just spending time on your front to stretch out your hip flexors. And then we're obviously working on knee extension exercises, static quads, inner range quads, etc. So all versions of the range. So you can see here someone just doing a basic knee flexion extension, and we're working on abduction as well, particularly if you're an above knee amputee, so that your single leg balance on that side is supported and you're ideally avoiding any unusual walking patterns like a glute med type gait pattern. We want you to have the flexibility, endurance, and obviously re-educating that balance on the single leg before you have a prosthesis. And then your general function as well. We're always looking at that in the background, knowing that even for people that are prosthetic users, they often don't use it all day or every day. So we need those backup options for when that's not possible to use. In terms of considerations for prosthetic rehab, so we're thinking about what were you like before? Were you a household ambulator? Were you really fit and active? And that can really influence our expectations. That being said, you never know how much the person's, for example, if they had a wound and were on long-term antibiotics, they might actually post-amputation have a lot more energy and be a lot more well. So we take it into account, but it certainly doesn't limit what we would provide that patient. But you are thinking about what comorbidities they have, the state of the remaining limb, and that, that's going to start giving you a picture of the person's prosthetic potential. And we're also thinking about the patient's goals and what they want to get out of the program. So throughout these phases of rehab, the stump is hopefully following this trajectory. So a fresh amputation, it's healing, it's got the RRD on. That actually should have gone on in ideally recovery after theatre, unless the medical team have said otherwise. And then the shrinker garment that I mentioned earlier. And you might actually wear your RRD on top of the shrinker once you are cleared to have a shrinker. The shrinkers are made of quite rough material, so they have to be quite healed before they'll put a shrinker on, because it can cause deterioration if the skin is still fragile. So that's something to consider. As mentioned, we're thinking about the patient's goals. So is it for walking, or is it just a cosmetic leg? Their cardiovascular fitness, and I'll show you a slide with the energy requirements shortly of walking with a prosthesis, but it needs to be taken into account, and it can help guide expectations. Their learning capacity and cognition. If they have poor cognition, then some patients have a carer who we provide carer training for prosthetics to make that feasible. But they need to be quite invested and a consistent support in that patient's life. Standing balance, obviously, as an above knee, you have to stand to put the prosthesis on. So there's some sort of cut-offs there. You have to be able to stand to be able to participate in the program if you're an above knee. Previous level of mobility, and then a thing called an AmpNo Pro, which is an outcome measure developed by Bob Gailey, who's a senior amputee physio from the US. He's developed that outcome measure that's sort of our go-to in terms of predictive scores. Other outcome measures that we use are timed up and go, 10-meter walk test, 6-minute in the Berg, and then the AmpNo Pro becomes an Amp Pro once you have a prosthesis. So it splits you into 5K levels, from cosmetic to non-prosthetic type category to, community ambulator, high level, potentially back into sports and recreation and that sort of thing at K5 or K4, sorry, that's an error there. And as we're evaluating, we're also looking at the client's goals and working out if they've changed in time and whether we need to change our practice to help accommodate some of those goals, or it can help to guide expectations and we can educate patients around those goals. As mentioned previous, this is the energy expenditure. So you can have a look at that, but you can see that, being an above knee amputee takes an extra 65% energy to walk rather than being a bilateral below knee. So as soon as you're adding a prosthetic knee in, it becomes much more demanding. In terms of donning and doffing, that's one of the first parts of the prosthetic phase of rehab. So we're teaching that, stump and prosthetic care, then looking at weight transfer. So you can see this physio, hand on the hip, practicing weight shifting in the parallel bars. Then we work towards gait re-education, progressing from the parallel bars to a walking aid. And then once you're out and about, general mobility, and also, as mentioned, thinking about getting on and off the floor. We talked about the avoidance of flexion contractures, and we're starting that from ideally, day post surgery, because they're really hard to eliminate once they're there. And then if you think about what the potential consequences are, we've got this prosthetic alignment shown here. So you can imagine how that would affect dynamic balance and function if you've had to have a prosthesis fashioned. You've got limited range and limited strength to control that range, and you've got a much higher chance of falls and a much higher chance of being reliant on a walking aid long term. So just some images now of donning the prosthesis. So you can see they're popped into the socket with a sock underneath, and they're doing up a Velcro cuff there and having standing practice in the rails. This is an above knee amputee putting on a prosthesis. So as you can see, they're having to have quite decent standing balance and weight bearing and endurance on their other leg while they put that prosthesis on. And it's got a knee in there. So if they put their weight into the toe, if they shifted forward with their center of mass, then they would break that knee. So they're being quite cautious about maintaining their safety while they put that leg on. Thinking about gait retraining, I've popped a couple of links in there because there are some good resources on the internet just in terms of strategies for gait training. Resisting at the hips is a really good one. Some facilitated walking. There's some really good videos. Just be aware that a lot of those have been funded by private prosthetic companies. So it's often based around really high-end componentry, but a lot of the time the strategies are really useful and you can kind of apply them regardless of the componentry, unless it's something that's very specific to a type of microprocessor knee. So just keep that in mind if you see something unusual. So once we've progressed out of the parallel bars and then, ideally we're out on a gait aid and maybe you've gone from the parallel bars to a forward walker or crutches and then to maybe a stick or unaided. We're thinking about, that general mobility so that you can function out in the community. So multi-directional, managing stairs, ramps, weaving, dual tasking, walking with a prosthesis takes an enormous amount of concentration in the early days, but we want people competent and confident with their prosthesis. And a huge part of the gait retraining is actually teaching people how to commit their weight load to the prosthesis. And we use the term down and through because we really want strong active use, but a real commitment to it so that your brain realizes that actually you are better by committing to it. In the early days, patients tend to be really reluctant to load, and that's normal and it takes time. And we're also quite cautious at the start because we don't know how the stump's going to respond. But once we know the stump can tolerate taking that load through the socket, then we really push to make that part of that pattern. There's also a tendency to not weight shift onto the prosthesis and also to rush off of it. So I'm doing quite a bit of work on ensuring the patient's practicing really weight shifting, really taking the load and doing almost a double count on the prosthetic stance time. If you can get a really strong prosthetic stance, then that will set you up for really good mobility in general and will really help your balance. Just some images of getting on and off the floor there, a couple of different techniques from patients. The sort of scramble into prone is lower level, or you can see with no prosthesis on it, you can see the other gent has a prosthesis on and is just using a stable surface to push up there. So let's put this all into a picture. So if we think about, okay, what sort of time frames are we talking? 20-year-old female, lives home with a family, born with a congenital malformation of the lower limb. It's been managed with specialized footwear, but it's really limiting her function. She's thinking about going to uni, getting into the workforce. So what can we do there? Okay, she's spoken to a surgeon, she's had a consult. She's elected to amputate with the goal of getting a good prosthetic level of function. So she has a week in the acute hospital and she's recovering. Then she came across for some inpatient rehab and she was seeing the physio the whole time, working on strengthening while she's waiting for the wounds to heal. 3 weeks after the amputation, she's done great healing. So 3 weeks is about as quick as we see. And she's given a shrinker, a compressive garment. And then after a week of wearing the shrinker, she has a cast taken by the prosthetist, who then takes 2 business days to make the prosthesis. Then we start in the gym, so in the parallel bars with just some standing, and we're practicing that donning of the prosthesis, standing, learning how to commit your weight to it, but we're checking the skin quite closely throughout that time. We're working together, myself and the prosthetist, to optimize function, making adjustments as needed. And then, as you can see in these pictures, people, working on dynamic balance and that sort of thing once they're in the safe phase, once we've learned that their stump's going to tolerate things okay. And then we're working on, weaving, dual tasking, higher level balance. Ideally, the person is then out living a full independent life in the community, utilising their prosthesis. That's what we would hope for everyone. And then down the track, after they've finished using their what we call interim or publicly funded prosthesis, they will have their prosthesis funded by a secondary body when the time comes and their stump has stabilised a bit more. And most people can return to some form of sort of social life and activity, and we are a big fan of peer support. Thank you so much. This link here, I've just realised I've gone a couple of minutes over time, sorry, but the link that you can see there is actually a really fun video of amputee prosthetic users who are dancing to a pop song. So I didn't have time to show any of the videos today, but feel free to take a look at the links when you get a minute. Now, I'd just like to say thank you so much for your time, and I'll be with the panel for any questions. Thank you.
Thank you so much, Monique. Thank you for covering so much of data in the 15 minutes. Next speaker is Dr. Charita Pereira. Dr. Charita is the Senior Consultant Physician in Rehabilitation Medicine at the Flinders Medical Centre and the Orthotics and Prosthetics South Australia. He's also a Senior Academic Lecturer in the School of Medicine at Flinders University. He's a Fellow of Australasian Faculty of Rehabilitation Medicine at the Royal Australasian College of Physicians. He holds a master's degree in sports medicine from the University of New South Wales and a graduate diploma in musculoskeletal medicine from the Flinders University. He has more than 15 years of experience in amputee musculoskeletal and general rehab. He'll be talking to us on pre-amputation counseling and the possible post-operative complications that can arise during rehab. Over to you, Charita.
My name is Dr. Charita Pereira, rehabilitation physician from the Flinders Medical Center and also at the Flinders University in South Australia. I'll be making this brief presentation on Amputee rehabilitation, and I thank Dr. Lakshmi for the invitation. Today's lecture will be focused on 3 learning objectives. I'll be briefly talking about the epidemiology of lower limb amputations in Australia, on pre-amputation counseling, management of complications following amputation. When we talk about the epidemiology of lower limb amputations in Australia, data done approximately 10 years ago showed that the incidence of amputation in Australia is about 32.5 per 100,000 population, meaning about 8,000 lower limb amputations are performed annually. And in Australia, roughly, it's about 22 surgeries a day. In comparison, incidence of amputation in India is about 62 for 100,000 population, and close to 1 million individuals with amputations are in India. So these are data I collected from a publication in 2016. So it's quite a prevalent number considering the population in the 2 countries. Well, in Australia, if you look at the demographics of amputees, majority are males with a 2-to-1 ratio, and the large number of them are over the age of 65, with average age of about 70. There's high prevalence of smoking and invariably large connection with diabetes, hypertension, coronary artery disease, and stroke. So these factors make our amputees very vulnerable population. Therefore, the morbidity and mortality of amputees are quite high in Australia, and therefore the life expectancy of vascular amputees, especially together with any diabetic complications, are very short. The numbers show that for a lower limb dysfunctional amputee, the 1-year survival is about 69%, going down to a 5-year survival of about 35%. For a below-knee amputee, 1-year survival is about 75%, and 5 years is about 37.5%, whereas for a above-knee amputee, it is much lower with about 50% 1-year survival and 22.5% survival at 5 years. So this shows our amputees are very vulnerable population with low life expectancy, especially if they have undergone amputation due to vascular disease and also diabetes. Therefore, when you talk about amputee rehabilitation, it is not just simply providing prosthetic service, but should consider the amputee as a whole patient with goals and ambitions. Then we come to the stages of amputee rehabilitation. We describe 5 stages, some places describe 7 stages, but nevertheless, we have to consider the pre-operative or pre-amputation stage, post-operative management, pre-prosthetic rehabilitation, prosthetic rehabilitation, and long-term follow-up. I'll be more focused on the pre-operative management of our amputees. For this, we consider conducting pre-amputee counseling. It is always preferable if our amputees are counseled prior to undergoing the surgery, and most of the time the vascular surgeons or the orthopedic surgeons, when they are planning surgery, would call on us to give some pre-amputee counseling. But sometimes it is not possible because some of the surgeries are emergency operations and life-saving procedures, and therefore there's no opportunity for us to conduct any pre-amputee counseling. The counseling involves a multidisciplinary team with a medical person, preferably a rehabilitation physician, together with a nursing, physiotherapist, and also prosthetist, providing a more comprehensive and holistic counseling session. We should educate the patient about the physical needs, about the physical needs of being an amputee, the functional prognosis, talk about pain, which I will discuss a bit later on, realistic short and long-term goals. And preferably, if there's opportunity, they should be placed on what's called a pre-rehabilitation or preoperative rehabilitation program, focusing on cardiovascular fitness. Preemptive pain management is vital to prevent post-amputation symptoms or post-amputation chronic pain. This has been well documented in different studies, as you can see. A study published by Jensen in '97 shows preamputation pain is very much related to the phantom limb pain after surgery. So controlling preamputation pain is vital when we look after amputees. The next stage in preemptive counseling, which a lot of us tend to forget, maybe due to lack of resources, may not be performing, is psychological counseling. It is well documented that amputation is a triple threat to the person because it involves loss of function, loss of sensation, and the loss of body image. And it's well documented patients with adequate warning and preparation fare much better in the post-surgical period and do much better in the rehabilitation program. And also all the amputees are more prepared for life in illness because they all experience several setbacks in their health by the time they have reached amputation stage. Therefore, they are more prepared for this adaptation for amputation. So we find a lot of the young, healthy adults are finding it hard to cope with an amputation stage. Next part of my talk, I'll be focusing a bit on the complications for a low limb dysfunctional amputee. The 1 year survival is about 69%, going down to a 5-year survival of about 35%. For a below knee amputee, 1 year survival is about 75%, and 5 years is about 37.5%, whereas for a above knee amputee, it is much lower with about 50% 1 year survival and 22.5% survival at 5 years. This shows our amputees are very vulnerable population with low life expectancy, especially if they have undergone amputation due to vascular disease and also diabetes. Therefore, when you talk about amputee rehabilitation, it is not just simply providing prosthetic service, but should consider the amputee as a whole patient with goals and ambitions. Then we come to the stages of amputee rehabilitation. We describe 5 stages, some places describe 7 stages, but nevertheless, we have to consider the pre-operative or pre-amputation stage, post-operative management, pre-prosthetic rehabilitation, prosthetic rehabilitation, and long-term follow-up. I'll be more focused on the pre-operative management of our amputees. For this, we consider conducting pre-amputee counseling. It is always preferable if our amputees are counseled prior to undergoing the surgery, and most of the time the vascular surgeons or the orthopedic surgeons, when they are planning surgery, would call on us to give some pre-amputee counseling. but sometimes it is not possible because some of the surgeries are emergencies, operations, and life-saving procedures, and therefore there's no opportunity for us to conduct any preemptive counseling. The counseling involves a multidisciplinary team with a medical person, preferably a rehabilitation physician, together with a nursing, physiotherapist, and also a prosthetist, providing a more comprehensive and holistic counseling session. We should educate the patient about the physical needs, about the physical needs of being an amputee, the functional prognosis, talk about pain, which I will discuss a bit later on, realistic short and long-term goals. And preferably, if there's opportunity, they should be placed on what's called a pre-rehabilitation or preoperative rehabilitation program, focusing on cardiovascular fitness. Preemptive pain management is vital to prevent post-amputation symptoms of post-amputation chronic pain. This has been well documented in different studies. As you can see, a study published by Jensen in '97 shows pre-amputation pain is very much related to the phantom limb pain after surgery. So controlling pre-amputation pain is vital when we look after amputees. The next stage in preemptive counseling, which a lot of us tend to forget, maybe due to lack of resources, may not be performing, is psychological counseling. It is well documented that amputation is a triple threat to the person because it involves loss of function, loss of sensation, and the loss of body image. And it's well documented patients with adequate warning and preparation fare much better in the post-surgical period and do much better in the rehabilitation program. And also old amputees are more prepared for life in illness because they all experience several setbacks in their health by the time they have reached amputation stage. Therefore, they are more prepared for this adaptation for amputation. So we find a lot of the young, healthy adults are finding it hard to cope with an amputation stage. Next part of my talk, I'll be focusing a bit on the complications of following low-limb amputation. In this area, the most important part is pain management. And pain management, we can discuss about post-operative pain, residuum or stump pain, and phantom limb pain. Post-operative pain is like any other post-operative trauma to the tissues where there's bones, nerves, and soft tissues have been dissected and surgically repaired. And this pain is expected to resolve within a few weeks with lessening of the edema and the wound healing. Sometimes we end up with residuum or stump pain, which are mainly related to local factors like poor circulation resulting in tissue necrosis or wound adhesions or hematoma formation, or in this case, an allergic reaction to a dressing. And therefore, it is important we thoroughly inspect our amputation stumps on a daily basis post-amputee stage, because these complications can be easily avoided or managed if detected early. Another thing that's a phenomena is regrowth of the nerve endings or formation of neuroma, which is quite common, and most of our amputees do have neuromas, but not all neuromas cause pain and distress to the amputee. And therefore, it is important that we recognize this and manage with appropriate investigation and therapy. What are the ways of managing this neuroma pain? Maybe using other than using oral analgesics, is doing local procedures such as injection of corticosteroid and anesthetic around the neuroma. Or even we can do a radiofrequency ablation where heat is applied to the end of the nerve to cause suppress the impulses being transmitted. If these conservative measures fail, the ultimate treatment option is the surgical excision of the neuroma. Next, I'll talk about phantom limb pain, which is a very unique phenomenon with amputees. It's a very complex neuropathic pain felt in the absent body part. The mechanism depends on the length or the time period for the amputation, and most of amputees do experience some form of phantom limb pain, or some just do not consider it pain. It's more like a sensation where they feel their amputated body parts still being present, where they have to touch or itch or move these phantom parts of the limb. Unfortunately, about 5 to 10% of amputees may end up with significant phantom limb pain affecting their lifestyle and day-to-day activity. And these pains are described as burning, significant shooting or stabbing type of pain, and some even a cramping type of pain. So it's quite important that we recognize phantom limb pain, differentiate it from phantom limb sensation, and treat appropriately. So early phantom limb pain is normally attributed to the damage or cutting of the nerve endings, which cause some excitability and formation of some immature neuromas. These do respond very well to medication and should improve with time, especially wearing prosthesis and desensitizing the stump. And also once the tissues matures, we find that this pain will gradually dissipate. Some of the more common medications we use in this stage are the antiepileptics or tricyclic antidepressants. Later on, the phantom limb pain may persist or gradually get worse, and this is more related to a central phenomena where there's a memory of the pain in the central nervous system, either in the higher cortex or in the spinal cord level. Unfortunately, this type of pain will respond poorly to common medications or surgery or prosthetic treatment, and may require some cognitive behavioral therapy or mirror box therapy or mirror therapy, where you hold a mirror focus facing the sound or the non-amputated limb and looking into the mirror and seeing the image of a full limb on the other side. So most of the time we find mirror therapy very effective in upper limb amputees, but we can also use that in lower limb amputees. Sometimes if the pain gets worse, we may have to resort to more drastic techniques such as infusion of lidocaine or ketamine in a specialized chronic pain setting. So when it comes to managing phantom pain, there's a good collection of options here with pharmacology, as I mentioned, tricyclic antidepressants, gabapentin, pregabalin, or other anticonvulsants, or ketamine, or lidocaine infusion for severe pain, or maybe a surgical intervention such as a nerve block, a neurotomy, or inserting a spinal cord or local stimulating mechanism. We can also try adjunct or adjuvant therapy, such as a transcutaneous nerve stimulation, or TENS machine, mirror therapy, biofeedback, and so on. So there's a plethora of different techniques we can try to manage our patients. Next, I'll be talking about heterotrophic ossification, or HO, in amputees. This is basically formation of calcium or calcification of tissues, or new bone formation, where it is not outside the normal bones. So HO can occur most of the time in traumatic amputees, but it can also occur in our vascular or diabetic amputees. It is well documented HO formation in blast injuries or dealing bone situations. Management of HO can also be quite difficult and may need several mechanisms or several methods of management. So initially, we could try accommodating these heterotopic bone epiphytic ossifications in our prosthetic manufacturing or casting to accommodate these bone changes. There's also some evidence of trial of bisphosphonates, especially the sodium methyltranate, but the evidence is not that convincing for us to recommend as a first-line treatment. Sometimes trialing non-steroidal and anti-inflammatory such as indomethacin may help in early stages. But ultimately, the heterotopic ossification causes significant pain and difficulty in wearing a prosthesis. The surgical excision is the definitive treatment, but this should be undergone only once the bone has matured with a minimum wait time of at least 12 to 14 months. We can do a bone scan and look for any activity, and once the bone has matured, the surgical excision can occur. This is an X-ray of a young amputee we had some time back who developed heterotopic ossification when the conservative management failed to accommodate this very sharp, pointy bone causing tissue irritation and pain. We had to resort to a surgical excision. And following the procedure, this patient did quite well with prosthetic fitting. So in summary, I went briefly on the epidemiology of low-limb amputation, especially in Australia, preemptive counselling and managing complications following the amputation. Thank you very much.
Thank you for the wonderful presentation, Dr. Pereira. Next, we have the panel discussion. We have Dr. Pereira already joined in, and Shannon and Monique will be joining in shortly, I would expect. So we learned a lot about the amputee rehab in Australia. Thank you for accepting our request. It is at such a short notice, and preparing such a beautiful talk covering all our learning objectives very well. So what I would like to highlight is, like what Dr. Pereira said, the amputee rehabilitation is not just about giving away the prosthesis, but we could see that it extends far beyond that and also far ahead of that. It starts well ahead of it. I would invite Dr. Pereira to join in the panel discussion.
Yeah, thank you, Dr. Lakshmi. It's a pleasure.
Thank you. Hello?
Yeah, can you hear me, Lakshmi?
Yes, yes, I can. Yeah. Welcome, Dr. Pereira. So the pre-amputation counseling, you said only the planned amputees received, isn't it?
Yeah, it's an opportunity because if it's an urgent or emergency amputation, obviously we are lucky to have what's called a nurse practitioner, a nurse who specializes in amputee rehabilitation, and she has been specially trained to counsel and follow these patients. As you know, amputee, once they become our clients or patients, it's a lifelong relationship. So it's important to have one point of contact if possible. And so pre-amputee counseling, if somebody's got a Charcot's foot or some sort of a chronic condition where the patient is going to have an amputation in the future, it's always important that we contact them early and educate on the expectations and what the goals of the patient is. But obviously, if it's urgent, like a trauma where surgery is happening within 24 hours, or where the patient's actually not very well, so like sedated or in a lot of pain, with a large number of opioids, so may not be possible to conduct that pre-amputee counseling. But wherever possible, we do that. Even a brief session, even if you can't do a multidisciplinary or a combined counseling session, at least 1 or 2 specialist therapists or the nurse or the doctor or even the prosthetist or the physiotherapist can visit and talk to them. We have shown that it's really helpful for them later on in their rehab progress.
Yeah, talking about the pain management, what are the analgesics that you commonly use for subacute pain management, and how long do you prescribe them? Yeah.
So immediately post that, so most of our amputees do come get a block in theater post-op, but when they come to us, of course, all those interventions have stopped. We tend to treat, if required, opioids for a short term. We use either oxycodone or oxycontin, which is a long-acting endone or oxycodone preparation. But we try to avoid continuing for too long because that's something that we don't want the patients to get used to. With regards to neuropathic pain, we commonly use pregabalin, depending on the patient's age. If it's an elderly patient, we sort of start at 25 milligrams at night to see if they can tolerate it. And a younger patient, maybe 75. So we start taking at night, and if they still got phantom pain during the day, we give twice a day dose. So those are the 2 commonly used medication. And then, of course, we titrate the pregabalin as required. What we can see is once they start using their prosthesis later on, the requirement for these anti-neuropathic medication diminishes. So most of our long-term amputees, maybe after 12 months, I would say less than 25% will be on any kind of regular analgesic medication.
I think you add on amitriptyline also if needed, isn't it?
Right, amitriptyline also we add on, especially if they got problems sleeping at night. Again, we are a bit cautious with the elderly, as you know, with the amitriptyline, you can get the dry mouth and postural hypertension, and also can affect the cognition a bit as well. So we try to avoid if possible. We try to start with the pregabalin, and then amitriptyline can be added later on.
Okay. Monique has joined us. Hello, welcome, Monique. I was waiting for Shannon. I think she's also trying to join in. While we are waiting for her, can you talk to us more about the removable rigid dressing? The way to progress, how often does the patient takes it off, and how often do they recast it?
Sure. Can you hear me okay?
Yeah.
Yeah, beautiful. In lieu of Shannon being here, I'll talk to this. It really is the prosthetist domain in our healthcare model, but basically, usually the rigid removable dressing goes on in recovery after the surgery, unless there's a specific reason. Most often it's when the surgery has been done by plastics and there are sort of other complex issues around wound healing, but most of the time it's going on in theatre. In the early phase of healing, because of the risk of swelling, it comes off minimally, usually just for dressing changes and wound reviews and that sort of thing. And ideally it's only coming off for sort of 5 minutes maximum in those first few weeks. So the leg is bagged with a plastic bag for showering and all of those sorts of things. Then down the track, we usually try and get patients to become quite independent with taking it on and off, and aware of the goal of minimising time with it off. And then once the swelling's sort of more controlled and the patient can go into ideally a shrinker, the compressive garment that was spoken about in the presentations, it's coming off a little bit more often if they're starting to wear a prosthesis particularly, or otherwise just for sort of stump management around showering, moisturising and managing skin hygiene and all those sorts of things. So it really depends, and it depends for the individual how much they're reliant on it for volume control. We have some patients who have to keep using their rigid removable dressing long term to manage, along with their shrinker, to manage their socket fit for prosthetics. But most of the amputees, I would say, after about the 6-month mark, have started to take it off overnight or for periods of the day, or have started to stop wearing it. We do also encourage patients who are at a higher risk of falls to continue to wear it as a protective measure when they're not in their prosthesis. In terms of how often they're recast, it comes down to how much the stump itself is changing in shape. So we have a monitoring and management system around that, where the prosthetist is referred to for review once they're wearing a certain number of thick socks underneath it. So once it's becoming too loose, there are very rare instances where it's come off for a dressing or that sort of dressing change, and the stump swells and it actually can't go back on, and they're asked to come in and make a new one for the larger stump that's sort of swollen because of the time frame that it's been off.
Yeah. It is made within 2 hours after the surgery, isn't it?
Ideally,
yeah.
Yes. Ideally, in reality, we know there are complexities around meeting that indicator, but yes, in an ideal world, there's we have challenges around weekend surgeries and times of referral and that sort of thing, but that we do work towards getting it on as quickly as possible.
Dr. Pereira, there is a lot of evidence supporting the removable rigid dressing over the soft dressing, isn't it?
Yes, certainly, because the evidence shows it reduces, of course, the stump volume control is easy, reduces pain, reduces time to wound heal, and of course, it's a protective cover. So we earlier on, when I started, there are few patients who actually had trauma to their stump when they have fallen in the middle of the night and had to have revision surgery. So that sort of prevents that direct trauma as well. And sometimes even in a rehab setting, sometimes after a shower or when they are in a wet situation, I mean, these removed rigid dressing is like almost part of their day-to-day routine. It doesn't, because that risk is there, they can fall and damage their stump. And as Monique mentioned, like sometimes weekends or especially in the middle of the night, a trauma case and you have amputation, then putting RRD is almost impossible for our prosthetic team. So sometimes the surgical trainees or the registrars are educated to do it. Whether they do it or not is a different question, but sometimes they can do it as well.
Is there a non-removable rigid dressing also that the surgeons give?
Non-removable. I think Shannon's there, but I think there are ones that you can. There are commercially available ones where you apply and strap and you, I think, pump air. Shannon may be able to tell us about it.
I think she's yet to join. She's told me that she's trying. She's there. Yeah, she's there.
Can you hear me?
Yeah.
Yeah. Hi. So I guess the blow up ones, I think Dr. Pereira is talking about, basically what they are is they're sort of like a bladder style. So there's an air chamber around, and there's usually struts either side with sort of like what we call a stubby on the bottom, sort of like the bottom of a crutch, like an auxiliary crutch. And they can be used for sort of early gait and pressure, but I'm not exactly sure they're used as an RRD primarily. Yeah, we normally use the fiberglass versions, definitely.
So what are the precautions that you take while you give an RRD? You will be applying it early on with the drain and all in place, right?
Sorry, I'm in really bad internet at the minute. Do you mind repeating that?
Yeah. What are the precautions that you take while putting on like doing an RRD early on within 2 hours of the surgery?
Yeah. So the drain. Yeah, so obviously we like our doctors to have a really superficial dressing. There's sometimes drains or I guess pain release into the stump directly. We normally try and tape them to the skin and just keep them out of the way, and if they can stay in place, that's preferable. And then we put on one thick fluffy sock, and after that we apply the RRD, so it's all custom and it can be contoured to whatever shape. We do notice a lot, though, that the distal end is usually quite larger than sort of up around your knee area. So a lot of the times we normally have to add additional packing around that area, or we sometimes chuck like a little split or a cut either down the medial or the lateral side to make donning and doffing a lot easier.
And the nurse will be removing it only during the dressings, as Monique said.
Yes, correct. Yeah, no more than 2 to 5 minutes at a time, because the swelling can just increase quite significantly quite quickly, and if it is left off for longer than that period of time, we normally have to come and replace it. So that's not ideal discomfort, because they're not the funnest things to put on and off all the time, especially in those first few days post-surgery.
Dr. Pereira, what is your take on immediate post-operative prosthesis?
Immediate post-operative, I mean, for lower limbs, I must say
Yes.
we have never done that.
Yeah.
But I mean, there are evidence for upper limb where they immediately post-operative, they fit a prosthesis in some centers, but lower limb, while I've worked, I've never.
Yeah, I think they discourage it for geriatric patients, especially if in the diabetic amputees.
Yeah, that's one of the reasons.
Yeah. They prefer RRDs over immediate post-operative, unless it's a young patient, isn't it?
Even our young ones, they are going to be merely traumatic ones or congenital deformities. So our young ones are, again, my experience, I've never had that done in Adelaide. So.
Yeah, most of the protocols.
Pediatric case that I was involved with, they orthopedics was the main doctors involved, and they put almost like a fracture cast on his stomach. But he had a Boyd's amputation, so he had some internal fixed screws.
Sorry, can you repeat that, Shannon? We couldn't hear you.
Sorry. I don't think I said anything. My internet where I am is a little unstable. I didn't know. Was there a question? Sorry.
No, nothing. It was only that we didn't hear you properly.
Oh, was it the question on the side? What's the life of a prosthesis? How often does the prosthesis?
I think the internet is playing off. That's okay, Shannon. So the rigid dressing is one thing I would like to promote in India. I would like more people to come up and do it. Can you suggest some links or materials available in internet?
Wear and tear.
I can post you some evidence
for young patients.
Done by,
and how would you define an ideal stop? I'm sorry.
That's okay, Shan. Yeah, Dr. Pereira.
Yeah, I can send you some links to you.
Okay, I can share
good
it.
evidence. Published evidence.
So we were actually in the process.
I'm sorry, Shannon, your internet is not helping at all.
Sorry, Charita. I was just about to say we made a recording sort of ticked off by SA Health once it's.
Yeah. Oh, okay. So I could find some resources in Enable New South Wales, Enable NSW. If people want to look at it, they have given pictures and videos on how to do the RRD and things like that. So I could see that it's quite useful. So next we move on to we have a question posted in the chat box. What are the rate of stump revisions and what is the most common cause for it? Our surgeon has posted this question.
Yeah, stump revision. So the question also says especially late stump revision. So
yeah.
So I must say it's not very common because we try to avoid surgery because, as I said, most of our patients are vascular and diabetic patients, so they probably having another surgery may not be the best option. But if we need to do that, most of the time it's either that there's something wrong with the surgery where they have left the fibula too long and it's causing problems with our fitting, which I must say it's very uncommon nowadays. The next common is the heterotrophic ossification or bone spurs, which I mentioned earlier in my talk. Then sometimes there may be tissue invagination where there's a lot of remnant redundant tissue, which has really shrunk and made it very difficult for our prosthetist to fit a proper socket. So we may actually tidy up those extra bits of soft tissue and skin and make it nice and smooth. We may get the plastic surgeons mainly try to do that for us. Or maybe they got neuromas, which are sort of not responding to our non-invasive methods of injections, and therefore we may have to get them opened up and resected, and then at the same time they may just tidy up the stump as well. Another common reason is again in emergency or people who don't do a lot of amputation, but they have to do an emergency amputation, may not bevel the bone properly. And then that again causes a lot of problems later on. So we may ask for a revision to nicely bevel the bone afterwards.
The not getting a properly beveled bone is one of the greatest challenges that we face here. So beveling will be the anterior part of the tibia and
yes.
A shorter fibula.
That's right. You have to have the fibula shorter and beveling of the anterior part of the tibia or the femur.
Okay. And Monique, can I ask you when to proceed to the permanent prosthesis? Because we'll be giving the interim prosthesis to begin with, isn't it? So when do you change it to permanent one?
So we have approximately a 7-month interim period with the prosthetics, and then it's a matter of usually in the lead up towards the 7-month mark, there is a bit of variation there. Sorry, I should add in that there's sort of a window period because in theory it would be 7 months after the amputation, but in reality, if the person has taken 6 months to heal, then we're commencing prosthetics in the interim phase. Really, it's about stump stability. We don't want to use up external body funding. So at the end of interims, which has all been paid through public health, then we're moving on to the alternative funding source. And that changes depending on the age bracket of the patient. So once we feel like the stump is stable, and it's a minimum of 7 months post amputation, but usually it ends up being about 6 months into the prosthetic period as well, because the prosthesis in itself has that act of stabilizing the stump through the consistent pressure through the tissues. Then we move on to definitive. So at minimum 7 months post amputation, but sometimes it's longer depending on when they started interims. And a lot of that is around not wanting to use up funding with the patient then needing a new socket really quickly and potentially not having the funding available to do that.
Yeah, here the patients pay from pocket, so we also suggest them to wait until the stump is matured before they invest in a good quality prosthesis. And so, how often does the socket change happen during the interim prosthetic training? Usually,
the prosthetists work really hard to make modifications, and we do a lot of the work before they make the first socket around trying to shape the stump. And I've noticed in the chat there's a comment, what would you consider the ideal stump? And so just to speak to that as well, the ideal stump is fully healed, the skin integrity is looking really nice. Ideally, the suture line isn't adhesed at all to any underlying tissues, because that can cause significant issues with prosthetics in terms of the rigidity of the socket and then the soft tissues. If they're not compliant with the socket, then you get shearing forces when they're trying to ambulate with the prosthesis. And ideally, it's a conical shape so that you can distribute the pressures really nicely and not have that sort of bulbous end, because obviously that affects the circumference of the entire socket and affects your fit. So if we're set up with a fairly good starting point with a stump, then often the prosthetists, they do an amazing job at adding packing, heating areas out when needed, making modifications, adding certain socks and those sorts of things. So look, commonly in that 7-month period, they might need 1 socket. The most I've seen, I think, is 4, but that was a person who changed significantly. And there is the odd person who can use the same socket the entire program. That being said, usually they've had modifications made throughout the interim period, and when they do get cast for their definitive socket, it is still quite different to the first cast that was taken.
Yeah. When the patient is paying from pocket, that's a lot of money to invest. So we suggest them to use their free Jaipur foot first and then move on to the definitive with a good quality prosthesis if they need. What else? The partial foot amputations, Dr. Pereira, what are the options that you give the patients?
Partial foot amputees we do provide them with a prosthesis which has got a toe filler and a foot plate to accommodate the missing sort of the partial foot part. If there's there's no stability with that method, we may also have to add a ankle foot orthosis incorporate to that partial foot prosthesis. So there are a few ways we manage them. It is also included in our free limb scheme, so they get it for free of charge. I must say, with the partial foot prosthesis, is a little bit different to our normal transtibial or below knee amputees, where we don't have the interim phase or definitive phase. We try to fit a prosthesis once the surgical wound has really healed nicely.
Okay. So I've seen carbon fiber AFO with the toe filler. That depends on the level of amputation, or how do you decide whether it's just a foot plate or an AFO with the toe filler?
Shannon may be able to answer, but if
Shannon is not there.
Again, it depends on the level amputation and the type of foot control they have. If they don't have a good ankle control, then probably you need to give a AFO. But if there's a relatively good control, they got the tip anterior and the posterior working quite well, and they can invert and evert well, and they can manage to walk, then probably just having a foot plate with a toe filler may be enough. But if their general movements and balance is not good, maybe have to resort to a FO.
Yeah, we get a lot of ulcers on the anterior aspect of the partial foot amputations just because of the stump going into equinus. I think in that case, it might be better to provide an AFO with a toe filler.
Yes.
So the next question is about upper limb amputations and congenital limb deficiencies. What's the general management for congenital absence of both upper limb, especially when independence of ADL is the prime concern?
That's a challenge. General management of both upper limbs. So, of course, you try to. I mean, it's a congenital absence, so it is mainly a pediatric approach. To be honest, I may not be able to answer that because I have never seen a congenital absent bilateral in our practice.
Pediatric will be managed by a different team, isn't it?
Yeah, definitely. So it's a challenge because they would have brought up without their limbs. So it depends how they would have managed as a child. It's going to be very hard to introduce upper limb prosthesis when they become adult, when they never used one.
Shannon would have been a better person to answer, but she's not in the picture.
I'll just add that.
Connection. Yeah.
I am still here.
Um,
I don't know
Oh, are
where I
you?
am.
Yeah, can you
Yeah.
please answer, Shannon? You have worked in the pediatric unit, right? Can you please mute others himself?
I think he's, oh, there we go. To be honest, I haven't worked with bilateral upper limb amputees before, nor have I met someone in that circumstance. I have had pediatric experience, but majority of my pediatric experience has definitely been from the orthotic side of things. So I'm really sorry. I'm not sure what light I can shine on that.
Okay, that's okay, Shannon. We do get a lot of adult patients with bilateral upper limb amputations. We do get electrocution injuries and all in India. So we are struggling with some of them. We are even presenting one case today. To what percentage of your patients do you prescribe myoelectric hand? What's your take on that? Dr. Pereira?
Yes, so again, we are lucky that a basic myoelectric is included in our free limb scheme now. And also younger patients can access it through the insurance scheme that we have for younger amputees. To be honest, we have very little, very few upper limb amputees. I mean, we see 1 or 2 a year, so it's not very common in South Australia. So the myoelectric, the issue is a lot of our amputees upper limb, if it's only one limb, even if it's the dominant limb, they tend to, focus on the remaining limb and not bother a lot with the amputation. But once you fit one, most of our amputees do well with the body powered ones. There are few we have fitted myoelectric, and even I'm not sure if you're familiar with the eye limb as well. We have a few eye limb amputees as well. So they are not very commonly used, but because they need a lot of what you call dedicated therapists, plus the patient has to be really motivated to undergo months and months of training. Yeah, so that's another challenge. We find that they may not persevere with such an intense therapy program, because you've got to get all these parts moving and picking up the signals and the bulkiness of the prosthesis, and so that discipline has to be there. Having said that, we have a few clients with our service who are using myoelectrics.
Okay, that's good. So how do you compare it with the body powered, functionally?
Depends what they do. So we have farmers who have got their arms injured during farming accident, and for them, there's nothing better than a body powered one. It's because it's robust. You can get it wet, to go into the field, carrying. So it's. But if it's a manual working person who's doing office job or desk job, or want it for cosmesis or just light day-to-day work, so we have a few who are like that as well. And we have most of our patients use both, so they may use the body part for some occasions, or maybe use a myoelectric or even a cosmetic arm when they go out in the community.
Okay. Yeah. Do we have any questions remaining in the chat box? I don't think so. So thank you for all that information. Thank you for spending your weekend with us. We owe a lot to you to have participated with us with such a short notice. And thank you for making such excellent presentations. Thank you so much, Dr. Pereira, Monique, and Shannon.
Yeah, thank you very much for inviting us. I'm sure Monique and Shannon feel the same. So we are quite happy to help you out in the future if it's needed.
Thank you so much.
All the best. Yeah.
Yes, thank you very much for having us.
Thank you, Monique.
Yes, thank you.
Thank you, Shannon.
Sorry about the poor internet connection.
That's okay. That's all right.
Okay.
So we shall move on to the second session. That will be on how to improve amputee care in India. sorry, we are running a little bit late because we had a few connectivity issues. We have Dr. Prasad Matthews and Dr. Fatima Hanina in our second session. Dr. Prasad Matthews is a rehab physician from UK. He did his post-graduation in orthopedic surgery and rehabilitation medicine from Trivandrum Medical College. And he's a member of Royal College of Surgeons, England, and British Society of Rehabilitation Medicine. He's currently working in NHS UK since 2008. He took 2 years of sabbatical in 2017 to 2019, where he worked as a senior consultant at the KIMS Health, where he did all the hard work to establish our rehabilitation unit and the KIMS Health Limb Center. He is currently working at the Royal Wolverhampton Hospital. He's managing the prosthetic unit there. We welcome you to speak to us, sir. He'll be speaking about the amputee rehabilitation in UK. Over to you, sir.
Lower limb amputee rehabilitation at the National Health Service in the United Kingdom. The Artificial Limb Service in England was set up during the First World War. The Special Interest Group for Amputee Medicine, SIGAM, is the medical body. It is a part of the British Society of Rehabilitation Medicine. Amputee rehabilitation services are delivered through POCs, or Prosthetic and Amputee Rehabilitation Centers. It is led by a rehabilitation medicine consultant. Statistics. Lower limb amputations account for 91% of total amputations. Males, 70%, females, 30%. The commonest cause of amputation is vascular disease. It accounts for 52% of patients. Of these, 42% are diabetics. Trauma accounts for 11%, tumors 3%, 50% of amputations are transtibial amputations, and 34% are transfemoral. Upper limb amputations account for 8% of amputations. Phases of rehabilitation. The rehabilitation of patients having a lower limb amputation should be considered in the following phases: pre-amputation, amputation, post-amputation, primary prosthetic amputee rehabilitation, amputee review, and maintenance. Pre-amputation. Pre-amputation consultations should include discussions on realistic rehabilitation goals, prosthetic options available, projected outcomes, adaptee equipments, home and vehicle adaptations. Amputation. Amputation should be performed by a surgeon with experience in operative techniques to get a good amputation stem. The aim of surgery is to form a residual limb of appropriate length, good healing of skin, avoiding excessive soft tissue distally. Bone ends must be beveled to avoid sharp edges. The knee joint should be preserved whenever possible. Post-amputation. The main considerations in the post-amputation phase are good post-operative analgesia. Rigid dressings afford control of residual limb edema and maintain a straight knee joint. Compression socks improve comfort and reduce skin edema. Early walking aids like pomade and femoral are used in the clinic. Patients are introduced to local and national support groups. Primary prosthetic rehabilitation. The primary prosthetic amputee rehabilitation phase starts the decision that a functional process can be used by the patient. The aim is to enable the patient to achieve maximum functional independence. The patient should know what to expect and, more importantly, what not to expect from an artificial limb. Patients are graded in their mobility from K1 to K4. This helps select the appropriate components and the best design of the process. Computerized gain analysis remains mostly as a research tool and get used. Body entry and foot care of the normal limb is important, especially in diabetes. 50% of diabetic amputees will develop a serious contralateral lesion within the next 2 years. Amputee review and maintenance. Once the amputation stem has stabilized, the patient has acquired basic skills in using the prosthetic limb and achieved their initial goals. The amputee moves on to the established user phase. This usually commences by 18 months post-prosthetic delivery. Some
Water consumption. Too much of water consumption.
The issues in the maintenance phase are skin issues, falls, increased energy requirements for walking with the prosthesis, osteoarthritis of the hip and knee in the intact limb due to excessive loading, stem shrinkage and loosening in the socket, phantom limb pain, and psychological problems regarding body image. Outcome measures. The outcome measures we use clinically are impairment measurements like socket comfort score, numerical rating scale for pain, global disability scores like Bartle index, mobility scores like SIGAM grades, care levels, and timed walking test, psychological scores like hospital and anxiety and depression scale, and Rivermid life goals questionnaire. Lifestyle. We provide customized covers for the limbs. Running blades are provided for sports. As a patient's increase in their functional ability, we upgrade them to processes that permit more activity, like microprocessor knees and hydraulic angles. Prosthetic prescription. Prosthetic prescription is based on the needs of each patient. For this, we use the care levels, a rating level used by Medicare to indicate the person's rehabilitation potential. K0, user does not use the prosthesis. K1, limited household use. K2, limited community use, and the patient walks with a fixed cadence. K3, the patient is able to walk with a variable cadence and uses the limb for vocational and leisure activities. K4 is a very active adult or athlete. I would like to show you some of the processes which we provide in a clinic. For partial foot, we provide shoe form fillers or customized silicone prosthesis. For science processes, we give a socket with a low profile carbon fiber foot attached to the socket. The socket has a window which helps the bulbous stem fit into the prosthesis. For transtibial stem, a laminated socket with suction valve, liner, and a foot according to the mobility needs of the patient is here. This is a knee disarticulation process. A knee joint needing short clearance is attached. This is a transfemoral prosthesis with a suction socket, a hydraulic knee, or a microprocessor control knee joint is given. On the right, a cosmetic cover has been applied over the prosthesis. This is a hip disarticulation processes on the left and a hemipelvectomy processes in the middle. The hemipelvectomy process and HD process are usually given with a hydraulic hip joint and a microprocessor controlled knee joint. Prosthetic components include feet, knees, hips, adapters, and task-specific components. The various types of feet are thatch foot or solid ankle cushioned wheel for K1 level of mobility, multi-axis and carbon heel feet for K2 level of mobility, low profile foot for attaching to science processes, hydraulic and microprocessor feet for K3 level of mobility. These are some of the feet we give in a center. From left to right, you can see the thatch foot for K1 level mobility. In the middle is the multiflex feet for K2 and K3 level mobility. On the right is a low profile carbon fiber foot for science processes. Feet seen in the slide are on the left is the Osur Proflex with the carbon heel. In the middle is the Echelon hydraulic foot and ankle. And on the right is the Elan MP hydraulic ankle with the carbon fiber foot. The knees can be semi-automatic knee lock or shackle, hand-operated knee lock, weight-activated stance lock, hydraulic knee, polycentric knee, or microprocessor controlled knees. The knees shown in the slide are on the left here the shackle or semi-automatic knee lock, where the knee remains locked during the stance phase. In the middle is the ESK, endolite stabilized knee, and on the right is the 3R49. Here, when the patient puts weight on the knee joint, it locks while the patient stands. The knees shown here are on the left is a 3R80 Autobot hydraulic knee. In the middle is a polycentric total knee. And on the right is an Orion microprocessor knee supplied by Blackstone. Hips can be free, locked, or hydraulic. Here, the hips we see are on the left is the Autobox 7E7 mechanical hip. In the middle is the lockable hip. And on the right is the Helix hydraulic hip, which is usually given along with the microprocessor controlled C leg in hip disarticulation. Adapters are connectors between the socket and components. They are critical to achieve correct alignment and length. The adapters permit sliding, rotation, and angle adjustment between components that can be waterproof as well. Here we see the different types of adapters. In the middle, you see the socket adapter, which is attached to the laminated socket. And on the right is the tube adapter. Task-specific components are used for specific needs of the patient, like running or swimming. Torque absorbers allow high impact loading, then especially when the patients are running. Rotators permit rotation of the body on the field. And we have quick change adapters as well. Here on the left is a quick change adapter to change from a normal foot to a carbon fiber blade for running. In the middle is a teletorsion adapter by Blatchford, which permits twisting and turning so that the patient can swing a golf club and play golf. On the right is a socket rotation adapter, which can rotate the knee 90 degrees inwards to permit the patient to sit cross-legged, as in yoga posture. Here on the left, you see the carbon fiber running blade, and on the right, you see the swimming ankle with foot. Osteointegration is directly attaching the prosthesis to the bone by a surgical procedure. There is no socket and socket-related complications are avoided. The sensory feedback to the patient while walking is much better than that of a normal prosthesis. NHS provides microprocessor knees from different companies like OSU and Autobot. Blackford is the main provider for NHS components and manufacturer for National Health Service in the United Kingdom. Their microprocessor knee is called Orion 3. Thank you.
Thank you for that wonderful talk, Dr. Matthews. We next move on to our case discussion by Dr. Fatima Hanina. She did her post-graduation in rehabilitation medicine from the prestigious AIMS, New Delhi. And since the past 1 year, we have her with us working as a rehab physician at KIMS Health. Her areas of interests are neurorehabilitation, pediatric rehabilitation, and amputee rehabilitation. She'll be presenting a case on myoelectric limb and giving us an overview about the rehabilitation at KIMS Health Limb Center. Over to you, Dr. Hanina.
Thank you, ma'am. Good afternoon, all. I'm Dr. Fatima Hanina, rehabilitation physician of KIMS Health. I'm here to speak on amputee rehabilitation in KIMS Health. I'll begin with a case presentation. Sorry for the delay. Coming to the case presentation. We have a 32-year-old male married who was working as a contract worker in Kerala State Electricity Board. He presented to us with alleged history of high voltage electrocution at worksite in July 2020. He presented to us in December with amputation of both upper limbs below elbow with a totally burned perineal area needing amputation of penis and scrotum, with suprapubic catheter for urination, with history of left clavicle fracture, and he was bedbound for 4 months and with no financial support. He was totally dependent on ADLs. His wife separated from him after the accident, and he is currently supported by his elderly mother and cousin. He was depressed. There was no bowel incontinence. His left upper limb was flaccid with no power, and there was weakness of lower limbs with hip of 2/5, knee of 3/5 power, and right foot drop. He had phantom limb sensations over residual limbs and perineum. He didn't attend any rehabilitation prior. He came to us through a sponsor who later on withdrew. His goals for rehabilitation were to be independent in activities of daily living, to get a functional hand, and to remove the catheter if possible. We started him on antidepressants. We discussed with urology, and they investigated and clarified that there was no other options other than to continue with suprapubic catheter. At the same time, our team started mobilizing him. His sitting balance improved, but we couldn't continue the IP rehabilitation as his sponsor withdrew, and because of financial constraints, he got discharged. He was with us for 1 month, but we kept him under follow-up. During follow-ups, it was noted that he started ambulating with support. His left trapezius and elbow extension power improved, but shoulder remained subluxated. There were no new movements noted in the left upper limb. And after discussing with our hand surgeon, he suggested to plan for nerve transfers in left residual limb. Again, due to his affordability issues, we asked him to do the same from Government Medical College. We gave a trial of body-powered processes for the right, but he didn't tolerate the straps of suspension due to severe neuropathic pain over the left residual limb. And hence it was decided that myoelectric hand for right would be the best option for him. And his left upper limb was supported in a sling. As we were convinced about his financial background, King's Health decided to provide financial support for his myoelectric hand. Myoelectric hand, called the B Natural of Tallinn Prosthetic and Orthopedic Center, which is located in Malaysia, has been arranged by a private vendor. Measurements are already taken, and he'll receive the limb mostly next week, and will start fitment and training in coming weeks. Though we couldn't attain his goals currently, but we are hoping we are on the way. As his limb is in processing, here I'm showing the Tallinn myoelectric hand of another patient. This is during the fitment and training session. This is a above elbow myoelectric hand. There is the gripping and opening of fingers, and also the thumb flexion and extension is also possible. They have both switch controlled and EMG controlled. So that was about the case presentation. Most of us know about Rehabilitation 2030. According to WHO, 1 in 3 people today are estimated to be living with a health condition that benefits from rehabilitation globally. According to them, in some low and middle income countries, more than 50% of people do not receive the rehabilitation services they require. So WHO in February 2017 launched the Rehabilitation 2030, which proposes 10 goals for uplifting rehabilitation, especially in low and middle income countries by 2030. And among the 10 goals, we would like to highlight a few. One is building comprehensive rehabilitation service delivery models to progressively achieve equitable access to quality services for all the population, including those in rural and remote areas. Developing a strong multidisciplinary rehabilitation workforce that is suitable for country context, and promoting rehabilitation concepts across all health workforce education. Establishing and strengthening networks and partnerships in rehabilitation, particularly between low, middle, and high income countries. And KIMS Health Limb Center believes in providing equitable access to the quality services to all the population. About amputee rehabilitation in KIMS Health Limb Center, we have the KIMS Health Limb Center, which is a charity initiative of KIMS Health in association with Bhagwan Mahavir Viklang Sahayata Samiti, BMVSS, Jaipur. We offer prosthetic limbs to all amputees approaching us free of cost, along with gait training and follow-up. We have well-trained staff. We cater only 5 patients per day. This was actually for assuring the quality of the limbs that we provide, but this has greatly helped us in this COVID era. Currently, we provide allotted timing for fitment and measurement for patients. We assess the amputees along their residual limbs, their architectural barriers, activities of daily living, the goals to achieve on receiving the prosthesis. We also assess their K levels, that is a functional levels, by amputee mobility predictor assessment tool. These are the assessment forms that we use in our center. Along with their physical assessment, we also assess the functional, their function, and also do a goal setting. This is the amputee mobility predictor assessment tool. It takes less than 15 minutes. And we make sure that all the amputees are being assessed by this before fitment. These are the measurement forms for upper limb and lower limb. They are mainly used by the prosthetist. For all the patients approaching us, we provide Jaipur limbs initially, which involves a Jaipur foot, the world famous Jaipur foot. Then in above knee processes, we provide the drop lock knee joint and Stanford knee joint. This is the drop lock knee joint. And as suspension, we provide the silation belt. A few words about Stanford knee joint. They are usually provided for young and high K level patients. They are designed by Stanford University with BMVSST. It was hailed by Time magazine as one of the 50 best inventions of the world in the year 2009. It is based on the polycentric concept, that is, during the stance phase, it provides stability, and during the swing phase, it provides the limb clearance, that's the foot clearance. And it is designed using the 4-bar linkage geometry. For below knee processes, we provide the total contact socket or the patellar tendon bearing socket, along with sleeve suspension or the cuff strap suspension. This is the cuff strap suspension. And for upper limb processes, we provide body powered cable control processes. And for above elbow, there will be a mechanical elbow joint. Then quick disconnect wrist unit and voluntary opening terminal device. This is the terminal device, voluntary opening. We provide gait training after fitment. Not many are willing to stay back for OP rehab program, and they continue their gait training at home. We want to ensure that the processes we provide are helpful and ensure the quality of our services. And hence, we suggest follow-up every 2 weeks and 3 months after checkout and discharge. Any maintenance are free of cost. For selected patients, depending on their functional ability and goals, we suggest longer follow-up and outpatient rehab. After residual limb stabilization, and if the K level is high, we prescribe processes through Osur or Autoboc if the patients are affordable. We suggest patients to wait for 8 months to 1 year before they go for the expensive options in view of the need for frequent socket changes. Meanwhile, we provide Jaipur foot and start Jaipur limb and start training as soon as the residual limb is ready, that is in 3 weeks time after amputation for a healthy stump. We do provide pre-amputation counseling and keep them under follow-up post-amputation also. This is one of our amputee during his training session. He is using a body-powered above elbow prosthesis. You can see the mechanical elbow joint. This is the figure of 8 suspension. So we were talking about amputee today, but I wanted to mention that KIMS Health Limb Center also provide a motivation wheelchair. This is a spinal cord injury patient who came to us for rehab, and we provided this ultra light wheelchair, active wheelchair.
Thank you for that, Dr. Hanina. Let's move on to the panel discussion. I'd like to invite Dr. Prasad Matthews and Dr. Hanina to join in.
Hello, ma'am.
Hello. Dr. Prasad.
Hello, can you hear me?
Yes, sir. Please join in.
Oh, okay. I'm extremely happy to see that you're continuing the very good work we started. Yeah. Dr. Hanina, I'm very impressed with that you have brought the evaluation criteria and the forms and all those things. So that's one thing I always insisted, that we should have proper documentation, evaluation, pre and post-op. and continuing the training and the preoperative counseling. I'm so happy you have instituted these things at KIMS. So continue.
Yeah. About the amputee rehabilitation in UK, sir. It seems like it's almost similar to what they do in Australia, isn't it?
The big difference is it's completely free to the patients. So we don't wait for 6 months. Most of the patients get the best possible processes as early as possible. So the criteria is just wound healing. And we have a pneumatic device called palm aid, and also we have the femoret. So we start training them on gait training straight away. And once the wound is stabilized, we never wait for 6 months. We are talking about something around 3 months. And we get the socket done, and then compression socks are given, multiple layers of socks are given. If they need a socket revision, we do it because at the end of the day, the patient doesn't pay for it.
Yes.
It's an excellent service. The difference is between Australia and here is that since the patients don't pay for it, we can select components, high-end components earlier in the phase. The main thing is the socket revision, but the components, we select the long-term components the beginning itself.
Yeah, I think there also the patient doesn't pay it. It's just a different funding agency. That's what they said.
Yeah.
That's all through the government only.
Yeah.
So what about the removable rigid dressings?
How it works is, for making the services sort of ideal, we have dedicated centers of excellence. So basically, we have one center for neurosurgery, one center for vascular surgery. Almost all our surgeries are done at the vascular surgery unit at Russell's Hospital, which is a hospital nearby. And so from the same team does. So we have the fortune of getting excellent stumps. Everyone looks identical. And they continue the immediate post-op rehab there. We have a dedicated physio team there. We go there and do our clinics in the other hospital, both the pre-amputation and the amputation. And we do use the rigid post-operative dressings. But then they come to our unit once the wound is healed. That's how it works here.
So in what time are they shifted under the rehabilitation unit? Approximately.
Let's say we don't wait as much as you mentioned in the earlier talks. Let's say wound healing, straight away they come for the palm aid training.
Yeah, I think they said they shift in 1 week. That's
yeah, we just wait for the wound healing, and we don't delay it here at all. We straight away go into the training phase. But only when the limb has stabilized, the edema and all that subsided with the shingle socks and all those things. So we are thinking about taking the cast, let's say, of something around 3 to 4 months down the line.
Okay. So the casting is done at 3 to 4 months down the lane.
That's right. Yeah. Once we're looking at the stump edema. We have some problem with cardiac patients and renal failure patients when they have a fluctuating.
Yeah. Exactly.
But most of the other patients, we are looking at something 3 to 4 months down the line after amputation with the first cast.
Okay. And what about the rehabilitation in India? You've had experience both here and abroad. Yeah.
I'm so happy to sort of extrapolate what I see in UK to India.
Yeah.
And Hanina has highlighted the difficulties socioeconomically. So initially that patient had a sponsor, then he withdrew. The socioeconomic and the government support is totally different in India. These are things we should discuss, but Sadhullah sir has done an amazing job in getting the limb center working, and I don't know how to appreciate sir for starting such an amazing center in Kerala. My question is, 50, 60 years, the Jaipur foot is there. Why didn't anybody start it in Kerala? And why don't we have a sort of a dedicated limb rehabilitation center in Kerala? Ours is the first and only unit in that sort of way. So these are things we should sit down and talk with the government, the social agencies, charitable organizations. I would be more than happy. I cannot give you the exact figures, A sea leg for a private patient in London will cost you £50,000. But at NHS, we get it at a fraction of the cost. So I've started talking to the companies. The cost outside and the cost that the company gives it to us is unbelievably different. That is one thing I'm discussing with the companies, where they can bring it to India, take out all the middlemen straight from the company to KIMS Limb Center, and all these even high-end prosthetics, we can give it at a fraction of the cost from the outside market. I cannot reveal the confidential funding details, but what I'm going to say is we can write down the cost like unbelievably, and I'm already working on that. And that's one thing I would like to discuss with the South when I come back, hopefully when I come to India in December.
I know that you also run business there, so you are very good at
what I'm trying to say is, we can make, if we have a will, we can make huge changes and bring innovations to India. And finance, we can sort it out. It's not impossible.
So, Dr. Hanina, how do you get referrals? What is the procedure to refer?
To KIMS Limb Center, currently we get referrals from our.
We can't see you. Just me.
And now we have the KIMS Limb. People can directly come to KIMS Limb Health Center, KIMS Health Limb Center by taking an appointment. We give them appointments, and they can come to us during that time.
So do they have to bring in any documents, or what is the usual procedure? They can just call in and register?
Yeah, they can register by calling. But when they come, we need documents like their identification, like Aadhaar card, photocopies, and photocopies of their original identity, and also their discharge summary. We want that because we have to give the document about the limbs we give.
So how many patients would we have catered as of now in the last 2 years?
Currently, we have reached a number that is about 700. Around 700 limbs we would have given because we have conducted many camps also in nearby places in Kerala.
Okay. So in Jaipur, they give the limb that day itself, right? But we have to call the patient back. Why is that happening?
Or else they have to wait here we don't want them to wait here, so we give a time of about 1 week to 2 weeks. We make it possible to deliver the limbs within 1 to 2 weeks, so we don't want them to wait a long time here.
Yeah, Dr. Matthews might be able to give a better idea. We had a hard time with the plaster of Paris.
Yeah. So these are practical things. Okay. So basically, I would say, please continue the pattern which you are doing now of 5 limbs per day. As I insist, quality takes precedence over numbers. So even if you go below 5, it is fine, but every single limb should be giving the patient maximum pain-free functional independence. So I would say, I personally, when I was also there, I used to tell Karandeep and also, do not rush the things. Every single limb you're giving to a human being for his independence. So quality, if you need to take 1 week, no problems with that. Take your own time. Here we take a cast, and sometimes the patient gets it after, let us say, a couple of weeks. Because sometimes when we have large centers, we send it to a center in Sheffield where they do the carbon. By the way, we give only carbon fiber sockets here. And we adjust it with multiple socks. Some people use up to 4 socks. We had a patient using 8 socks. So keep to the numbers as you set them. Even if you go down to 3 or 4 is fine. But please, quality is more important than numbers.
Yeah,
So
it would have been better if you could give away the prosthesis that day itself, because to avoid traveling, the patients do come from faraway places. But we had an issue with the plaster of Paris setting too soon in our humid climate. We had sacks and sacks of plaster of Paris getting all set within the sacks. So we couldn't really follow their protocol of giving the artificial limb that day itself. That's what has happened. So
one thing we also do that. Basically, we have two types of casting. Most of them is still plaster of Paris. We take the plaster of Paris cast, and one thing I found is they have some sort of an additive. I forgot the name of it. They add the additive to the plaster of Paris. Then just before you take the mix the plaster with the water, you add the additive to the plaster of Paris, and then that makes the plaster so much more, easy for the prosthetist to cast it. We do have a 3D scanner, the handheld scanner, where we put the markers on the patient's stump, the tibial tuberosity and medial and lateral flares and the tip. And we had a handheld scanner, which we use it, and straight away you can see it on the laptop screen, the socket design. You can make modifications, and this we send it online to Autobox, and Autobox makes it and brings us back a cast. So, but we still like the plastic iris. You take the plastic mold, and it's a handheld, hand skill by the prosthetist to give the near relief where is needed, extra pressure where is needed. So that's how we follow it. And this additive, I think we should get it in Kerala. That will prevent the plaster from lumping.
So about the high-end prosthesis, how do you decide it there to like whom to prescribe the
so basically, it is a discussion between the medical consultant, the prosthetist, the occupational therapist, and physiotherapist. So all four of us are in the clinic. And we look at three things. One is the age and the comorbidities. Number two is the weight of the patient. Certain components will not take above a certain weight. And number three is the care level mobility. We also use the SIGAM grades. So these are the three factors we take it. And depending on that, if the patient is a young and fit and active person, let us say K3 level, we straight away go for K3 level components. But if it's the elderly patient who just wants to transfer from wheelchair to bed, we straight away go for a sage foot with a simple mechanical knee joint. And that's how we do it. So in the beginning itself, we decide the final processes. The only change I've seen is that probably you need a few more socket changes down the line, and that's all right. Otherwise the components almost remain the same. Okay. Once they're really fine and running around, then we can upgrade it to MPKs or carbon fiber changeable blades for running. This is government scheme that all children in school should be able to take part in sports. So carbon fiber blades are provided to all children in school, free of cost.
Okay. Yeah. And what are your suggestions to improve amputee rehab in India?
Number one, as I said, starts with amputation and pre-amputation counseling. So what I would recommend for Kerala is we should implement video telemedicine widespread, and we should be linked to every single hospital that can refer patients to us, so that we can have a video consultation with the surgeon as to pre-amputation counseling and post-operative follow-up. Also, number one, telemedicine is very important. So we should have a working understanding with all the hospitals that refer patients to us. Telemedicine is very important, and pre-operative counseling and all those things can be. That is one thing. Improving the quality of components, which, as I said, we can discuss with the charitable organizations, corporates, and the corporates 5% of the profit they give it for CSR. If Autobox or Oslo or Blatchford, I'm already in discussion with Blatchford to bring them to India. So yeah, we can bring in high-end quality products at lower cost. That is another thing. And training the surgeons, as I said, if I take the photographs of every single stump here, you will not be able to distinguish which stump belongs to which patient. It's done by one vascular team. Every stump looks exactly the same. Lakshmi knows that I used to take photographs of all the amputation stumps there and document it. No two amputations are similar. So we need to sort of have awareness of that it is not amputation, not a procedure done by the resident at the end of the theater day. It should be done by an experienced surgeon because the whole future depends on the quality of the stump. So we need to do training to orthopedic surgeons, plastic surgeons, and vascular surgeons as to what we expect as an ideal stump. So that is again telemedicine, the medical conferencing. So that all starts. Lots of things we can do.
Yeah. Thank you so much for joining us today, Dr. Prasad Matthews and Dr. Hanina. I'd like to conclude the session. I'd like to say the message will be, as Dr. Pereira said, amputee rehab is not about just giving away the prosthesis. It starts way before that and extends a long time after that. It should be a multidisciplinary team approach and started early on. Think about the rigid removable dressing and try to reach out to the maximum numbers. The NGOs like BMVSS tying up with the corporate hospitals is not at all a bad idea. It ensures the quality. At the same time, it reaches out to the maximum number of patients, fulfilling the WHO goals. Thanks for your patient listening. So I conclude the session by that. Thank you so much.
Thank you.